Hi, this is the second of the PCMHT podcasts. I'm Dr. Rosie Walwyn, specialist grade psychiatrist, and I'm joined today with Sally Kirby, lead pharmacist in PCMHT.
Yeah, so as Rosie's mentioned, my name's Sally and I'm a pharmacist in the primary and community mental health team, and I work in certain networks within Sheffield, offering medication reviews to patients prescribed mental health medications. So today we're here to discuss the deprescribing of psychiatric medications. For the purpose of this podcast, we're going to be discussing deprescribing antidepressants, antipsychotics and mood stabilizers, and the general principles we're going to look at around deprescribing. We won't be covering benzodiazepines or Z drugs today. There's really good guidance from NICE on those, and services like Likewise Addiction in Sheffield can support with patients who need help in that area. So before we wanted to go on to talk about stopping medications, we just wanted to have a think about why we prescribe. So Rosie, before we go into more detail, could you outline perhaps why these medications are started for patients in the first place?
Yeah, sure. So really, when we're looking at prescribing medications, the goal is quite simple. So it's to improve the person's overall quality of life and to reduce symptoms. And the other thing that we find is that medication can sometimes, for some people, also be helpful in helping them to be able to engage more effectively with psychological therapies, which we know have a huge benefit and long-term impact for people. The other thing that we need to be considering every time we're prescribing something is that every medication comes with side effects. So when we are prescribing medications, we're always aiming for the minimum effective dose for the optimal duration of time. So that doesn't always mean lifelong treatment, and it doesn't always mean the top dose of every medication is where we need to get to with every patient. Sally, I was just wondering whether maybe now we could talk a little bit about what sort of referrals you get into the PCMHT pharmacy and what sort of queries you get around stopping medications.
Yeah, absolutely. So we get referrals in from professionals within the primary and community mental health team, from GPs, and requests from patients themselves who are wishing to have a discussion or some advice around reducing or coming off psychiatric medications. And the reasons for that vary really widely, and it does depend on the individual. Some people just simply feel they don't need the medication anymore. So perhaps when it started, they were in a certain time or position in their life. They may have had certain stressors where they were quite unwell, and they needed some medication to help with treatment, as Rosie spoke about before, about improving quality of life and reducing symptoms, but their circumstances have changed. Some people never feel like the medication helps at all, so a bit like the opposite. So they feel like they're in the exact same position that they were in before, despite being on this medication, which often leaves patients wondering, well, do I really need to continue to take this because it's not really benefiting me? And we might look either at deprescribing or possibly even alternatives in that case. For lots of people, and probably the biggest reason for referral is because of side effects. So whilst people's symptoms may or may not have improved, they're finding that they're getting side effects, which is affecting their functioning and quality of life. So some really common side effects that we get referrals for are around weight gain and other effects that come on from that, sexual side effects, sometimes feeling of emotional numbness, brain fog, as well as some physical side effects. So patients who have excessive sweating, which is perhaps can be quite distressing for them as well, or movement side effects such as tremor or involuntary movements.
Yeah, thanks. I think that's a really helpful summary. Some of the other things I think people can be worried about are like the long-term risks that medications can have. So I know you've already mentioned weight gain, but thinking about some of the antipsychotic medication and the link to metabolic syndrome, and then the long-term cardiovascular risk that can come with that. And then there are other things where people are at another different point of their lives. Maybe people are wanting to get pregnant or breastfeed, and we need to think about medications around that period, which can, in terms of, I guess, getting help for some of those people, that sometimes the perinatal team can be quite helpful too. And then there are other things. People don't want to feel dependent on a daily tablet, or actually the medication isn't no longer available, and then this is a point that we want to like review medication. That doesn't always necessarily mean stopping for people, but it just gives us time to sort of pause and have a look at things.
Yeah, you're absolutely right. And as one patient I had put it, they just said, I just don't want to have to rely on this medication anymore. But every patient is different, and we always sit down and create a personalised medication care plan with that person, thinking about their history and weighing up the benefits of medication versus stopping medication, and perhaps the benefits of reducing and stopping medication as well.
Yeah, I think that's really important. So all the time when thinking about this, it's making this personalised and individualised for people. So when we're coming to think about the person sat in front of us wanting to have that conversation about, is this the right, with the right time and place for looking at reducing or stopping medication, first thing that we need to look at is stability. So what is their mental health like at the moment? Have they been stable for a long period of time? That may be a number of years for some people. And if so, then they're really at a generally lower risk of relapse when we're looking at stopping medications, and that would be perfectly reasonable to look at stopping and reducing that. And that it's likely to be something that would be very reasonable to manage in primary care if somebody's had a long period of stability. There are other situations where I think we probably need to be a bit more cautious. So people have had recent episodes of acute illness with their mental health, recent deteriorations, previous attempts to stop medications which have later led to worsening of mental health, or a history of severe illness requiring crisis teams or hospital admissions, or a history of multiple relapse after stopping medications. I'm not saying that for those people, deprescribing might not be possible, but it's maybe those sorts of people need to have a little bit more support, and possibly from secondary care services, or just a little bit more thought going in a little bit more monitoring going in for those people. In terms of the people that you maybe are reasonable to think about deprescribing in general practice, so yeah, people who've had maybe a long period of stability. The one sort of tip I would say is, I know that working in GP land, I appreciate how much pressure is on all your time and it's really tight. But if you have got time with patient in front of you to just find the last mental health letter, that can often be quite helpful. So I know myself, if I'm discharging somebody from clinic, I will write a little bit about their current medications, but with a plan to what to do in the future. So if this person's had a period of stability for a couple of years, they could look at reducing their medications. And I often give a little bit of a guide about how that could be done. So that might give you a little bit more information and support to be able to feel comfortable to do that in primary care as well. So Sally, when a patient comes to you for deprescribing, can you maybe just talk through what you would talk through with them when considering stopping medications? What sort of things would take into consideration?
Yeah, so the first thing is, I normally try and get a good idea from them as to what their thoughts are about coming off medication. Are they really keen to come off medication? Do they feel like, they want to come off quite quickly? Are they feeling quite anxious about coming off medication? Do they want to come off slowly? Some people are really worried about becoming unwell again and what that looks like. And other people are sort of quite keen to come off quickly because they're getting side effects. So again, it's really coming back to that individual and making sure we're understanding what their reasons for wanting to come off medication and what the possible benefits are for them. I'll often discuss sort of if they've tried to come off medication before and what that looks like, because that gives us a really good indicator. So often people will reduce medication on their own, quite quickly or abruptly, or even over a prolonged period of time. So what was that experience? And it may be that they experience withdrawal symptoms, and sometimes they can make the mistake of thinking those withdrawal symptoms are a relapse. So they say, well, I came off medication really quickly and I became unwell, so that must mean that I need it. Others have managed to successfully stop in the past as well, so that gives us a good indicator as to how easily they may come off medication. And we also talk about long-term goals, and just general expectations. So deprescribing doesn't always mean stopping completely. Sometimes it's just reducing the dose to minimise the side effects. and keep somebody well in terms of the mental health. And one big thing we look at is timing, so choosing the right time to reduce. So having a little bit of a look at what's happened in their life. So I know, Rosie, you just mentioned, have they had any acute illnesses? So that's important. Have they had a recent relapse? If so, we may say, let's just wait a little bit. But also, have they got any real stressors coming up? So that may be upcoming court cases, major family stress, relationship changes, school transitions for children, or significant anniversaries. So we tend to avoid any highly stressful times when we're thinking about starting that reduction.
Yeah, and I think that's really helpful, isn't it? And we need to think life doesn't have to be perfect, but we do want to avoid deprescribing during major upheavals, because I think realistically life's never going to be 100% perfect for everybody at any particular time. So it's really helpful summary of the points there. I think it would be helpful to talk around, if we've got somebody in front of us now that we've decided it's the right time to reduce medications, what would a sort of tapering plan look like for a person that you would see?
Yeah, and again, we get lots of questions about tapering schedules, and there are structured plans in the Maudsley Deprescribing guidelines. And ultimately, it's about tailoring the plan to the individual. So we say go slowly, where you can give the patient some autonomy, give them some autonomy over where and when and how frequently they reduce as well. I guess advising the patient to expect that this may not always be a smooth journey. So there may be one particular dose reduction that they really struggle with in terms of withdrawal side effects, and it may even be that we have to hold that dose reduction for a little while or go back up to a previous dose while things stabilise before we start trying again. So it's really important to work together with the patient to come up with the right dosing schedule. Thinking as well that it's often easier to reduce the doses from the higher doses, and those last bits can be the most difficult doses, where we may have to even think about using liquids or doing smaller dose reductions. And we would always advise to only reduce one medication at a time. Support networks matter too, so it's often families and carers who can spot those early signs of deterioration and make deprescribing safer, and ensure that somebody has a mental health care plan and a safety plan as well.
Thanks, that's really helpful. And I know we've mentioned a couple of times already thinking about withdrawal symptoms from psychotropic medication. And this is something that we are aware of, and that there's more work at the moment. And this has become a little bit more widely known with some work from Dr. Mark Horowitz. So withdrawal symptoms can occur on reducing psychotropic medication, and as Sally says, that those coming down the top doses might be a bit easier than the lower doses. And when we're looking at the withdrawal symptoms, it can be really wide ranging. And when you look into it, the list is almost any symptom in the book. So that can be a bit complicated at times. But thinking about some of the common ones that you see people reporting or are present, so tiredness or dizziness, some of them that are quite specific for withdrawal symptoms are brain zaps or electric shock type sensations. Alongside that, people might have some changes in gut symptoms, but also temporary mood changes, which of course means it's then a bit difficult if we're reducing medications and somebody's got a change in mood, thinking about, is that a withdrawal symptom or is that a relapse? It's really important to inform patients about the potential for withdrawal symptoms. It's not that everybody gets it, but it's that it can happen. And sometimes people, knowing that may happen, find the withdrawal easier to do, or easier to understand what symptoms are happening, so they're less anxious about them. In terms of trying to think about whether those mood changes are related to withdrawal symptoms or whether it's a relapse, guidance really is that if they tend to occur within the first few days or weeks of a reduction, they're more likely to be linked to withdrawal symptoms, and they're more likely to settle more quickly over time. However, a relapse, on the other hand, tends to occur later on. So I think just helping patients understand the difference from this prevents them assuming I'm having a relapse, so I must stay on this medication forever. So giving those people information just helps them through the process. So I think we've done a bit of a whistle-top tour there of deprescribing. So I'm just going to hand back to Sally to summarise our discussion.
So yeah, when we are reviewing patients, I guess some key questions to ask are, is this medication still helping in your current life situation? And are the benefits of stopping worth the potential risks? If that answer is no, and if the risk of relapse feels too high, then that's okay. Continuing medication is a valid and safe choice. Deprescribing should always be slow, personalised to the individual, and working with that individual to reduce the medication at a pace that feels comfortable for them. And stopping completely doesn't have to be the goal. Sometimes getting to a lower dose is where we want to get to, and that's okay, because a reduction can have reduced side effects and still providing some benefits to the symptom control.
Okay, well, thank you for that lovely summary, Sally. And that brings us to the end of today's episode, and we hope you found this conversation helpful.